Greetings to everyone. We are online now. Today, our meeting is about reviewing the psychiatric education. We are here for the intergenerational meeting for the third time. And our previous meeting was, or we started, I should have said, we have started by World Mental Health Day on 10th of October 2021. Then we had our meeting on stigma. Now, today we are having our third intergenerational meeting. It's about reviewing the psychiatric education and will try to answer the question, does it equip future doctors with basic proficiency in psychiatry? I will leave the floor, I will stop sharing and leave the floor for our moderators. Yeah. Please, Eugene, could you take the floor, please?
Right. Thank you, Bulan. So I think I would just hand it over to our two moderators, Ramin and Asmita. They are students from across the world, the world's apart, in fact, one from Malaysia and one from the States. And I'll leave it to them to chair and let's see where this goes. Ramin, Asmita, over to you.
Right. Thank you very much, Dr. Choshkun and Dr. Eugene, for the wonderful introduction to our team and to our previous intergenerational meetings. Good day, everyone, and happy 2022. Welcome again to the third installment of our intergenerational meeting, which I hope we can have more of in the future. So I'm Ramin, and together with Asmita, we'll be your moderators for today. Before passing it on to our panel of distinguished speakers, there's something I had actually planned to share. So last week, leading up to this intergenerational meeting, I had a batchmate of mine who asked me an interesting question. He asked me, why is it that psychiatry is a major rotation, a major posting in our med school? I'm here to be a doctor. Does psychiatry really come into play that much? So when I first heard that question, let's just say the first thought that ran through my head were not too polite. So, but I just calmed myself down. I took a step back and instead I told him, you know what? Why don't you join us? Why don't you watch our intergenerational meeting this coming Monday? Let's let the experts tell us why. So with that, without further ado, I think I'd like to invite our first speaker. Our first speaker is a psychiatrist and a medical lecturer of, he's a psychiatrist and medical lecturer at the Faculty of Medicine and Health Sciences of University Malaysia Sabah. He is also the Deputy Director of Hospital UMS Malaysia. And he brings his unique perspective on the intersection between medicine and the arts, so literature, movies, and so on. Some of you might recall his eye-opening presentation during our first intergenerational meeting, which was during the World Mental Health Day Zoom party. So he's none other than Dr. Nicholas Pang. Let's hear your thoughts, Doctor.
Okay, thanks, Ramin. Hi, I'm Nicholas here. I think you've oversold me a little. I just a little lecturer, and I do like reading and things like that. But well, to call it a fascinating presentation. Hopefully today will be no less interesting. Hopefully it'll be fascinating to some of you. I think the question given to me by Eugene, let me read it out because it's always good to see if the person given the question can actually answer it. There's a strong focus in the biological aspect of psychiatry in education. Can the psychiatric curriculum provide more detailed exposure to psychotherapy or related processes? And how to go about it so that it will be delivered in a balanced manner that remain relevant in a future medical career. So I'd like to underscore the importance of teaching people psychotherapeutic skills. In our university, we have come up with something called the ultra brief psychological interventions, which were not invented, but rather adapted, so to speak, by our boss, Dr. Wendy Shoesmith, who did it as part of her PhD. What she found in her PhD, she did a PhD in the public policy, mental health public policy. And what she found was that the public policy of mental health in Malaysia, to use the simplest possible term, is fairly screwed up because it's pretty top down. It's pretty much a little triangle of this sort, and everyone is seen by psychiatry doctors, medical officers, and psychiatrists. Everyone. It doesn't matter whether you have mild depression, mild anxiety, mild anything, you're seen by a doctor. And can you imagine the huge number of people waiting outside a room just to see someone who has some kind of psychological distress, which no doubt requires attention of someone, but that someone does not have to be a doctor. So the solution to that, there are of course a few ways of tackling it. The solution that the UK used in the early 2000s was something called IAPT, Improving Access to Psychological Therapy. So what they did was they vastly ramped up the number of clinical psychologists trained in the UK and just made everyone able to access a clinical psychologist. That may have worked in the UK with a lot of slack capacity and a lot of psychology training schools with a lot of graduates from psychology schools who need a job, frankly speaking. But that cannot be the case in an LMIC, that's a lower middle income country. We only have the barest number of clinical psychologists able to run a service, and let's not talk about the number of counselors we have, which is probably even smaller than the number required. For example, for a large state like Sabah is the second largest state on the island of Borneo, so it's about the same size as the rest of West Malaysia combined. Sabah has 2 clinical psychologists serving the population, and this is a doubling of the number from 1, which was the case until about a few weeks ago when the other main hospital acquired a clinical psychologist. So it's very easy for us doctors to say, oh, no, good. Subcontract all of the psychological care to psychologists and counselors. There are none. So the third option, which is relevant to the WPA section, obviously taking care of this group because it doesn't just take care of students, it takes care of primary care, is to ensure that every single doctor, every single person working in primary healthcare is able to perform basic psychological interventions. And actually, Dr. Wendy's PhD thesis discovered that if you upend the system, you turn it upside down. So instead of psychiatry being the preserve of psychiatrists, but basic psychological skills being compartmentalized into little 10, 15-minute interventions that can be taught to virtually anyone. So we're not talking about medical students. We're talking about literally cleaners, janitors, low-ranking members of the staff or anything on the wards who can actually, who have a post-secondary qualification and who can deliver psychological interventions. They are actually the people with the best amounts of empathy. But of course, we need to target the low-hanging fruit first. If we teach all medical students basic psychological interventions, we can significantly cut out the number of people who need to be referred to a tertiary psychiatric service, which means ourselves, which in a sense, what Dr. Wendy is saying is that if we do our job correctly in making sure that we task shift enough psychological interventions to primary care, we reduce our own jobs as psychiatrists. Because then our time is used much better as psychiatrists. Instead of this huge mass of mild, moderate severity psychological disorders that can be seen in primary care, we only we get to spend more time possibly giving better care to more complex tertiary medical conditions more suited for tertiary care. So we've started this ever since 2017 in our medical school, which is pretty much when Dr. Wendy started her PhD. She's just finished her PhD. It's taken 7 long years, but it's meant that we've had 7 years to fine-tune the system. In that 7 years, we have done quite a few things. We have basically been able to teach all medical students cognitive behavioral therapy, basic skills. We teach them all mindfulness basic skills. We teach them motivational interview basic skills for dealing with behavior change, not just addictions. And we teach everyone how to do sort of shared decision-making and psychoeducation skills, which of course may be slightly more relevant to psychiatry, but shared decision-making is something that's relevant to any kind of medical condition, really, to be honest. And it's very easy to teach skills that people think, oh, that's a bit of a joke to fill in the curriculum. We've incorporated it into our exam. So every single student coming for exams is aware that during the final exam, the exit exam, they will be assessed in psychological interventions, one or another. And you wouldn't believe in an Asian medical school or any medical school how much that suddenly improves the ability of any student to perform a psychological intervention. So we're very pleased with our students. What we found out when they go out into the world since like around 2017 onwards is that when we get referrals from our own students who become doctors and who call us back in return, because the world is quite small that way, there are not that many psychiatrists around. We find that they've already done all the basic things. They will call us and say things like, I've already done certain mindfulness interventions, I've already done certain interventions, but I can't handle it. And then you feel as if that referral is definitely a referral where things have already been tried at primary care, couldn't handle, send on to us, fair enough. I think that has really, really optimized the kind of patients we see. It has really empowered primary care, because remember, the original purpose of creating all these psychological interventions was the top-down, was the structure of psychiatry was screwed up. It was all top-down, but by democratizing all of these interventions and allowing primary care to do them, meaning our own medical students who then become doctors, who then work in the little villages and towns of Sabah, we give it autonomy to doctors on the ground to perform interventions, and they feel much better about themselves, because after a 15-minute consultation, they can either sit there and try and figure out what dose of antidepressant and go through a few checklists of depression, anxiety, or they can spend that 15 minutes performing a useful psychological intervention, makes the person feel better, and when they walk out, everyone the doctor just feels more of a sense of accomplishment. Again, medications-wise, there are very, very few types of medications available in primary care. So it's much better that we teach people how to prescribe complex psychological interventions like CBT and MI in simpler clients, rather than teaching every single primary care doctor how to prescribe medications. Because whatever it is, let's go back to the original success of psychological interventions compared to medicines. They're free. They're free to administer, and the efficacy is fairly good compared to the paid stuff. So with that, I'd like to hand over back to Ramin. That's just how we have incorporated psychological interventions into our medical school. We're happy for questions later, but I do have another meeting at some point. So any questions can be saved up and I can answer them by writing if needed later on, if it's too late. Well, I've taken up quite 8 minutes on case. Thank you very much.
Yeah, thank you, Dr. Nicholas, for that comprehensive sharing. I really like the idea of task shifting the mild to moderate patients to the primary care. By educating medical students early on about psychological interventions, we can actually ensure that only those who are having severe mental illness, those who really require more attention, are being seen by psychiatrists, and it's not taking up our valuable resources. So yeah, I think that's a very interesting way to change the way we educate our medical students. I mean, I'm one of them. Okay, so next up, we have our next speaker, who is an academic of international standing. She's an emeritus professor of epidemiology and international mental health policy. at the Institute of Psychiatry at King's College London. She has interest in mental health policy and mental health services, so it's definitely wise to consult her regarding psychiatric education in medical schools. So Professor Rachel Jenkins, the floor is yours.
Thank you very much, Raman. Yeah, I was wondering who you were talking about to begin with, and then realized. Thank you. And I'd like to congratulate Nicholas on his excellent talk, which I agreed with every word, really. I think that the IAPT programme in the UK hasn't actually worked very well. It's had a number of predictable consequences, really. The main thing of which is that it's de-skilled our primary care staff. It's meant that our primary care staff think that if they spot anxiety or depression, they can immediately throw it to one of these young psychologists instead of dealing with it themselves. So I feel over the last 20 years or so, since the IAP programme was brought in, our GPs now feel that mental health is not their business. It's always something that you refer, and it results in huge waiting lists, people waiting to be treated, when in fact the primary care team could have dealt with it perfectly adequately themselves. So that's one point. The second point is that, as I think Nicholas was also saying, mental illness is so common. You know, the epidemiology is 1 in 6 of the adult population generally. It's about 1 in 3 of primary care attenders. So you can't possibly refer 1 in 3 of your people. You have to regard it as core business if you're in primary care, that psychological problems will be dealt with just as much as the physical and the social. So I think this has the big implication for our training, which is that we need to train our students to be biopsychosocial in every consultation. I think that's the approach that we need to be instilling right from the beginning, not mental health in a separate silo, but that it's integrated with their physical and social thinking. And that mental disorders, of course, have social causes, social consequences. So do physical disorders, many often as well. So the social also needs to be in every consultation. So I think that's my first point about undergraduate psychiatric training, is to teach them to be biopsychosocial right from the start. I think the second point that I'd like to make is that it's to teach them about the comorbidity, that physical disorders and psychiatric disorders are so intertwined that they, again, it doesn't make sense to refer them off to a psychologist, because the psychologist cannot deal with the physical, and they're not always so good at sorting out the social either. So one needs to be aware that if you've got somebody in front of you, say with diabetes, hypertension, rheumatoid arthritis, some serious infection, they're also likely to be depressed or anxious. And if they are, it'll greatly affect their prognosis. So it needs to be treated. So so the first point is to be biopsychosocial. The second point is to really understand this, this high comorbidity. So you're training the students for whatever kind of doctor they become in the future, they will always be able to detect and address common psychiatric problems. So, which brings me to the third point, that a large part of the curriculum needs to focus on the common disorders, the depressions, anxieties, somatization, etc., so that they can deal with those kind of standing on their head on a bad day in the clinic, as it were. They can assess and manage suicidal risk very competently and safely. So they need to be taught less about strange psychoses and much more about the common disorders. Of course, we can also teach them about the psychosis, but not in the depth to which students are currently taught. So they'll be taught for the common disorders they're likely to face in whatever clinics they do in the future. Because if somebody becomes a psychiatrist, they'll get much more intensive training later on. But here we're talking about the medical students. I think the next point I want to make is that I think it is helpful for the training of a student to be not just focused on the clinical, but to teach about the broader health system and the kind of public health issues that surround mental health as well. So to have some understanding of mental health in schools, mental health in prisons, mental health in orphanages, if you like, mental health generally in the community, the importance of intersectoral working, what's happening with the traditional healers in the country that you're in, and how many people do they see with mental illness? What are the linkages between primary and secondary care? How much support does primary care get from the secondary care system, and how does that work? Some understanding of the national mental health policy and whether there's a suicide prevention strategy or not. How would you prevent suicide across a country? What are the issues you have to think about? So I think even at the medical student stage, it's really helpful to have that wider contextual understanding, because it'll stand one in good stead, whatever kind of work you go into later on. So I know it's a lot to pack into 6 weeks, but I think it's doable. Yeah, so I think that's all I want to say at the moment. Thank you. Oh, there's one more thing. The term task shifting always really annoys me. And I'll tell you why. It's because we psychiatrists often think that we see everything, you know, and we've got a lot of work, so we're going to shift it to primary care. But actually, if you sit in primary care, working in primary care, you see these conditions all the time. The tasks have always been in primary care. What we need to do is simply support primary care to deal with them a bit better.
Thank you so much, Dr. Jenkins. I completely agree with what you said about the biopsychosocial model of psychiatry needing to not only be in medical education, but we also need to start that in undergraduate studies. I can definitely see how that would have been beneficial had I experienced that earlier on in my career. So thank you. And next up, we have our esteemed guest, Dr. Roger Eng. Dr. Eng is a consultant psychiatrist and chief of service in psychiatry at the Department of Psychiatry in Kowloon Hospital in Hong Kong in China. He is the current president of the Hong Kong College of Psychiatrists, the Secretary of Training, the Asian Federation of Psychiatric Associations, and he's also the Secretary of Education for the World Psychiatric Association. He's also an honorary clinical professor of psychiatry at the Chinese University of Hong Kong and an honorary clinical associate professor of psychiatry at the Li Ka-shing School of Medicine. So without further ado, Dr. Roger Eng.
Hi, thank you for the invitation to speak in this talk. I heard about what Nicholas and Rachel have mentioned about the importance of mental health training for medical students. I fully agree that the current medical curriculum has to be substantially revised, given that everyone in six of the population suffers from mental health problems. It looks like that the proportion of education for medical students is not basically proportional to the type of patients being seen in their regular medical practice. So I think the duration of mental health training needs to be expanded. But I think there are a lot of reasons for the reluctance of the expansion of medical curriculum with mental health training. We actually did some survey back in 2017 and also in 2020. We had a survey that we did. Actually, I did this survey with Bülent Koskun here, and we had another study, global survey done with the World Federation of Medical Students. And we actually found that a lot of medical curriculum contain a very small amount of psychiatric training. And in fact, most of them are only in the form of lectures. So it's basically didactic training. And very small number of medical schools are actually offering experiential training. And in my opinion, I think in this era where a lot of medical students can have access to a lot of medical information or medical education, I think it's all the more important to concentrate the mental health training in the form of experiential training. So there should be more participation by the medical students in the form of work rounds, in the form of participating in outpatient clinics, involvement in psychotherapy sessions, etc. So that would actually enhance their interest and understanding about the actual work of psychiatrists. And they would also know better about the importance and interplay between physical and mental health problems. Of course, there is also a suggestion from the survey participants back in 2017. They suggested, actually, it would be lovely if we could simply dissolve the mental health training as a standalone subject. Instead, we should try to amalgamate our mental health training into other parts of subspecialty training, so that the subspecialist would understand that actually mental health is part of each different medical subspecialties. So this is what we think it would be important to revamp the current medical curriculum. Of course, in the Chinese University of Hong Kong, where I've been involved in honorary training and teaching, they have a very interesting program of supporting the medical students with mental health buddies. And these mental health buddies are medical students trained in identifying mental health problems. And that would somehow enhance the medical students' awareness of mental health problems. And they would also help the department of the medical school to be more aware of the importance of mental health, both for the medical students, for the teachers, and also for the patients. So in this way, they hope that the awareness or possibly the discrimination of mental health training by the medical leaders responsible for the medical curriculum can be reduced through this kind of practical support and help.
Thank you so much for that, Dr. Eng. I completely agree that it's very crucial to have mental health education be part of training for all these specialties in every aspect of the curriculum. So to follow up that riveting speech, we have a psychiatrist who teaches Master of Health Practice and Master of Health Leadership at the University of Auckland, New Zealand. He continues to support medical students as an advisor during their electives and during a project known as Population Health Intensive, or PHI, week. So Dr. Rodrigo Ramholho, we welcome you to share your thoughts.
Thank you very much. Can you hear me okay? First of all, to say that it's great to hear what everybody has been saying so far. I fully agree with every point made. We could perhaps afterwards have a discussion around how to better arrange, how to better connect the way in which we teach psychiatry for medical students with the health system in a way that then reflects the need to reinforce education and mental health with our general practitioners. Yeah, I'm thinking about the New York model here and things that I would like to bring up afterwards. But I would like to draw our attention now to something often discussed, but sometimes unfortunately not addressed, which is the hidden curriculum in psychiatry. And as you may know, the idea of a hidden curriculum is that there is this formal curricula that is often available to the students, but there is also these unwritten codes and messages and norms that are informal and implicitly taught in a classroom. And these are the hidden messages that are transmitted to the student, and that are also they become also part of their learning. And they are not often explicitly discussed, but they shape everyone's professional practice, and they are reproduced in the sense that they are learned by the students, they are incorporated by the students, and often retransmitted again to other students and colleagues and even patients. Perhaps a common example of a hidden curriculum are the practices, the professional practice and the informal messages that we often adopt in emergency situations in psychiatry, when on the one hand, the curricula may talk about the importance of prioritizing safety and prioritizing and respecting the patient's autonomy. But on the other hand, sometimes practice itself and informal discussions can transmit a message where there is a certain degree of disregard for the patient's autonomy, or where non-empathetic care is not challenged. And these are practices then that can be adopted and incorporated by the physicians. But I would like to focus our attention particularly on what happens when we teach about addiction, because I think this is an area where a lot of implicit beliefs and attitudes are closer to the surface and perhaps easier to identify. For example, we know that physicians tend to have a more negative attitude towards individuals with a substance use disorder, perhaps more than the one often held toward people with other mental health disorders. And perhaps at least part of the problem is the way in which we discuss substance use disorder in classrooms. And I would like to call our attention to particular two aspects of the often present hidden curriculum when we teach about addiction. One is the over individualization of the phenomenon of mental health disorder, or the overemphasis on discussing the individual rather than the individual in context. And the other thing is the over biologization or over medicalization, seen mainly through an emphasis on the more severe side of the spectrum and on pharmacological treatments often. So first, the not so uncommon practice of over biologicizing or medicalizing mental health. So as with most other mental health disorders, when we're teaching about addictions, we would often talk about it as an illness that exists independently from people. It have a certain physioneurological manifestation, associations with specific genes. Basically, it exists. And yes, it manifests in people, but we need to recognize it. We need to recognize the addiction. And we need to somehow look through everything else that the client is saying and be able to see if an addiction is there, if it is present, to make a diagnosis. And we here try to follow the same professional practice from other branches of medicine, where, for example, a general practitioner might have a person with some problems at home, but I need to move beyond that and check whether the blood pressure is beyond normal limits so that I can make a diagnosis of hypertension and treat it appropriately. In the case of addiction, it would be about listening to everything else, but to pay attention then to whether the necessary criteria are present or not, to be able to establish a diagnosis and prescribe very often a pharmacological treatment. So being fired from work and having lost touch with friends, for example, then becomes giving up important social or occupational activities. It becomes an item on a list that we need to check in order to make a diagnosis. And this is often followed by a discussion about the necessary prescriptions. And we may not want our general practitioners or psychiatrists to act this way, but when we talk about addiction in a classroom, and very often about other mental health disorders as well, we focused almost exclusively on the diagnostic criteria and the biological features of this of these illnesses and psychopharmacotherapy. And we are inadvertently teaching students a certain way of relating to these patients. So our patients are seen basically as carriers of diagnosis rather than individuals suffering the consequences of an illness. And I could here go in another direction as well and talk about the problem of making addiction an issue that almost solely requires motivation to be defeated. And in a way, I guess I'll do that by bringing up the second issue that I wanted to discuss, which is the decontextualization of individuals, or the over individualization of mental health disorders. And this is, in a way, I think, a byproduct of the over medicalization of mental health disorders, because we see patients and we support patients and we talk about patients in the classrooms and how to better support them. We might sometimes go a bit further than that and allow ourselves to include the family in our discussions. But I think we rarely incorporate discussions about what Professor Jenkins was saying about the public health issues, cultural, political, economic, social contexts that frame our patients' experiences of a mental health disorder. But not only that frame them, but also that contribute to their development and to the success or not of our therapeutic support. And this again reinforces the over-individualization of addictions, which are then easier to see as a person's fault or a moral failing or lack of motivation or a disregard for the impact of their addiction on their family and the larger society. And all of this, I think, also leads to some other unfortunate outcomes. One, what I already said before about how easier it is for physicians to have a worse attitude toward these patients, which in turn has an impact on the care that they receive and how they perceive that care, which being perhaps uninviting, then can lead to people not seeking support or hiding their problems. So what could we do about it? Perhaps a first step could be to know the extent of the problem. And there have been studies about medical students and physicians' attitudes toward addictions and mental health disorders and the role of the healing curriculum, but there's always room for more studies. It could also help to incorporate a discussion in the classroom about health inequities and their role in the development and the experience of mental health disorders and on help-seeking behaviors. When it comes to treatment, we should also perhaps encourage physicians to see their patients as people living in a specific context, to incorporate discussions about how social relationships, culture, perhaps with an intersectional lens, will impact their treatment or their recovery pathway in the case of addictions. But overall, perhaps not to forget that we are talking about individuals in contexts, that different contexts, very commonly different than ours, and that frame how they understand and react to their issues, and that can help the treatment or not. I guess in a way to try to perhaps rehumanize the way we talk about mental health disorders, and not to forget that humans are social beings mainly, that we live in social contexts and we are heavily informed by them. And to make sure that this is all explicitly discussed in a classroom context and not hidden, which can lead to all those unfortunate outcomes that I was mentioning. So that's just me. Thanks.
Thank you so much, Dr. Rodrigo. I think it's very interesting what you've shared, especially I found it interesting, particularly about the sort of the empathetic side of psychiatry that is sometimes overlooked, I would say. Like from my perspective, because I have sought help for my own mental health issues before. And so I've been on both sides as a medical student and a patient. And I really found, I really had an interesting experience where I observed that sometimes medical students actually forget that the patients in front of them are actually humans as well, with their own unique experiences and, you know, their own journey which brought them there. You know, it's not by any fault of their own. They just sometimes medical students often see their patients as, oh, okay, let's go talk to that case. That's a case of schizophrenia. That's a case of depression. So I think it's something that it should be kind of common sense. It should be the bread and butter of basic medicine, basic, in any posting. But I think it's something that we can improve on. So with that, let me introduce our next speaker, who is a senior professor and consultant psychiatrist at the Faculty of Medicine and Health Sciences of Utah University, Malaysia. He has worked as a consultant to the WHO in many countries. He is truly no stranger to psychiatric education. Professor Parameshwara Deva.
Thank you very much, Dr. Abrao, and thank you, and good afternoon to all of you, or good morning to some of you. Very sorry for being late, tied up with another lecture. Can I just, first of all, thank all of you for your presentations, which I managed to hear, but also just use 3 slides. I hope I can share screen. Yeah, okay. Can all of you see this? Can you see these slides?
Yes, we can.
Okay, good. So I just wanted to summarize everything I got to say in these 3 slides. A little crowded though. How to teach psychiatry and how not to. Unfortunately, as many of you actually pointed out, the teaching of psychiatry is very variable. I think Professor Eng mentioned from Hong Kong that sometimes it's just theory, just all theory. Actually, I've been to countries in the Pacific where they have not seen a single psychiatric patient, although there are thousands of them in the community, in the clinical setting. And all was teaching was from books. Until I went there for something and they said, "You're a psychiatrist, so can you teach us a real case?" I was surprised. They said, "You've never seen a real case before?" They said, "No," because the teacher herself is a nursing tutor, very keen to teach, but she has never been taught how to teach. So, of course, they all have this feeling that psychiatry is psychosis and nothing else. But my question is, to begin with, what is the objective of us teaching psychiatry in different settings? Whether it's Hong Kong, whether it's Vanuatu, whether it's in Malaysia, whether it's in India, or whether it's in Europe. What is the purpose? It varies a little bit because in countries like, say, Britain, with probably about 8,000 to 10,000 psychiatrists, you don't need a psychiatrist to be at the front line. You can have GPs who will deal with the screening, and the psychiatrists can refer cases where the GP cannot manage. In other countries like Vanuatu, there's no psychiatrist, there's no psychiatric nurse, and everything has been done by the 25 doctors in the country. So obviously the dealing of psychosis and non-psychotic illnesses are quite important in a setting like that with a small population spread out over hundreds of islands. So basically the objective is for future doctors and nurses and work in all healthcare settings, not just in psychiatric wards, in medical, surgical, outpatient, community clinics, and so on. Those things like depression, anxiety, and stress, and using counseling in some way to help them. Not for seducing students. I think we heard several times in our past discussions that the whole idea is to bring medical students to get interested in psychiatry and seduce them to become psychiatrists. Pardon my saying seduce, but that's exactly what I've learned for the last 50 years. There are many psychiatrists who are very keen to convert their medical students into psychiatrists. I'm not one of them. The next one is to teach skills in communication, which unfortunately not always taught in most medical schools, certainly in the low and medium income countries. And this can be done by using handphones. Now, even in the poorest country in the world, everybody's got a handphone, got FaceTime, and you can actually talk to a patient. You can record it and you can actually play it back and discuss what the interview went like. This has been done since 1970s when I was a trainee. And it still can be done, but very few people teach this communication skills routinely in psychiatry. Why psychiatry? Because psychiatry is basically a talking discipline. So if you can't communicate with your patients, you have a lot to look out for. Not just follow the teacher and say, do what I see, do not see what I do, but do what I do. Many times the teacher is wrong. So I think we need to teach interview skills as a basic thing in all psychiatry departments. The next one is teach where psychiatric stress is largest in number, not largest in the psychiatric ward. That is in the primary healthcare settings. There are thousands and thousands. In my primary care clinic that I go to and teach my students, there are 1,600 primary care patients from 8 o'clock in the morning till 10 o'clock at night. And at least 300 or 400 people with severe stress. But they are not managed because the GPs, they are not taught in that. And the psychiatrists don't go there because they're in the psychiatric wards. So we need to consider teaching where the population is large. We're all going to become doctors. We're going to teach the students to become medical students, to become doctors, and nurses to become nurses. And they'll be dealing largely with non-psychiatric patients. Those are with milder problems like anxiety and depression. Not just retain ourselves in the exotic high security psychiatric wards and learn all about schizophrenia, which most of us realize most of the patients will not fully recover. And they will not see in graduation when they come out as doctors, because only about maximum 5% of medical students ever become psychiatrists. So stop seducing psychiatrists. Seducing medical students to become psychiatrists. The next. So what's holding us back in the low and middle income countries? Psychiatric wards in most countries are almost exclusively meant for psychotic and severely ill patients. That's true in the low and middle income countries. Hardly any teaching facility for anxiety, depression, and stress and NCD-related psychiatry. That's a problem. There's a space problem and there's a venue problem. Psychiatric wards are everywhere. I've done work in different high-income and low-income countries, and they all have psychiatric wards, but not the psychiatric ward of the stress management type with anxiety and depression as the main place for teaching. That's not there. So repetitive, compulsive psychiatric, psychotic teaching for lack of space, not patients, because thousands of patients with anxiety and depression. But we are focusing ourselves in the psychiatric-psychotic wards. The last slide is, teachers can change curriculum in psychiatry teaching from psychosis to stress management. Faculties make curriculum. I've been a teacher of psychiatry for well over 50 years now. And faculties make curriculum, allocate curriculum. I've been in many faculty curriculum committees, curriculum discussions, and all sorts of things. And they are very strict about one thing. The curriculum must have fixed time. If you're given 42 hours, that's it. You're not going to get 1 cent more. You're not going to have 1 minute more. But what you teach inside that 42 hours is entirely of the psychiatrist, because the rest of the faculty doesn't know anything about what psychiatrists do. They think they're all teaching about mad people, which is true in a way, but they can be taught anxiety and depression. So low and medium income countries, undergraduate curriculum is far too elaborate, like the WPA's undergraduate curriculum that was set up, I think, in the late 80s when I was a member there. I found out that it is too elaborate. It cannot be used by the average low and middle income country. I would strongly urge that we focus in the low and medium income countries on less than 1/3 of the time with the psychosis and 2/3 of the time with anxiety and depression. There's a need for urgent traffic separation between undergraduate and postgraduate psychiatry. What's happening is those psychiatrists who are very enthusiastic and very energetic, they teach everything and overload the student, not getting them prepared to teach the primary care psychiatry or the anxiety, depression, stress management psychiatry in the future role as doctors, of which less than 5% will ever become psychiatrists. Thank you very much.
Thank you very much, Professor Deva, for your very comprehensive and concise sharing session. Yeah, I do realize that in my experience as a medical student as well, there's a lot of emphasis on the psychotic disorders rather than the more common anxiety disorders. But if the student actually put in some effort and took some initiative and they attend the clinics, I think they would actually see many cases of patients with anxiety disorders and so on. So I think there's a balance that needs to be struck. Personally, that's my own opinion. So without further ado, we do have one more speaker today. So this following speaker, he's a psychiatrist and a medical lecturer of University Putra Malaysia. He's a practitioner of acceptance and commitment therapy, and he has this special affinity for sports, and thus he practices sports psychiatry as well. He's currently teaching psychiatry at the undergraduate and postgraduate levels, and he incorporates his acceptance and commitment therapy principles in his professional development education among us undergraduates. He also has interest in technology, specifically information and communication technology, and gamification of education. One of his recent projects was a 360-degree camera, incorporating it into virtual clinical skills training. And this is something I have experienced firsthand as well. So Dr. Eugene, you're up.
Okay, thank you very much. I did really feel the little pinch when you said that our curriculum focuses a lot on psychosis, given that I was the one that was actually involved in your teaching. But I do agree. I do agree with pretty much most of the things that's being said here. I don't have anything very fresh to add on. I think Professor Jenkins and Rodrigo pretty much have said up most of the things I'm going to say here now. But Ramin do has a point in the sense that I'm an ACT practitioner. So I do incorporate that in my day-to-day clinical practices and even my teaching. And that's where I would want to add on an additional layer or additional perspective to what has been said. The current curriculum, we do still need some level of basic psychiatry. We still need to teach the very core biological components to students. Otherwise, I don't think anyone could understand psychiatry as what it is. I do agree, we emphasize so much on that and we medicalize it so much that we lose the human touch, and it also results in students coming out as doctors who do not see patients as another human. And when patients come along bringing their psychological distress or psychological issues, most doctors cannot relate to it because the training was as such. It's very medicalized. And this is where I would propose an additional perspective or additional add-on to the current curriculum. In the way where we train students, we provide additional, earlier we spoke about biopsychosocial, so the psychological part, the social part, and Rodrigo mentioned about hidden curriculum. All of that could be taught easily, could actually be shared easily if we teach students narrative skills. This is something that has been mentioned a few times before in various research and topics, but it has always been a minor thing. But I do like that approach. Teaching students to find out what is the actual story behind each and every individual patient they encounter. Yes, they still need to learn the skills how to diagnose major depressive disorder. They still need to learn the skills how to differentiate one anxiety disorder to another. But at the same time, we teach the students, can they tell us back the full story in a narrative manner? What is the actual story behind this person that they are seeing that resulted with them developing the distress and the symptoms that they get? Often I find that when we show students the story, look, I'm seeing this, he or she has symptom A, B, C, but look at the full story. Look, he or she has gone through a particular scenario. This scenario has impacted the current feelings or thoughts that he or she has. Look at the upbringing, how that has brought up and shaped his or her perspective towards this current one. Look at the combination of all of this. And we often try to form this into a story. I don't take up the part about the actual biological component because they still need that to pass exams. But by giving that extra layer of storytelling, the extra narrative layer, it makes them more relatable. It makes them being able to see patients in a fuller holistic perspective and get a better understanding why a certain person might develop certain conditions. And it will also further allow them to understand why we do the treatment we do. It's not just giving medications. Sometimes it's supportive therapy. Sometimes it's actual brief intervention or even social intervention. All of those will come into play only if and when a student can see that there is a full story behind the symptoms. And I find that this skills is often missed out in curriculums across the world. It's not just us. And interestingly, this is actually not something new. When psychiatry began in the original many years ago, this is how psychiatry used to be. It used to be a narrative, of course, maybe in a Freudian dynamic perspective. And we kind of lost that touch along the years. And I would like to actually propose to suggest to bring that back. I find that adding this additional perspective will make psychiatry teaching much better. It will give them better understanding. And of course, not seeing another patient as just medical terms or signs and symptoms, but actually embracing and being able to understand the full picture behind whatever that they're seeing on the hand. And that's just my little quick add-on for today. And that's all. Thank you, Ramin, Asmita.
Thank you so much, Dr. Eugene. So I completely agree that we need to encourage students to relay back the narrative of patients to understand their diagnoses better. And that narrative layer of storytelling is absolutely invaluable to allow students to better understand why certain people develop certain conditions and how that gives way to better treatment and better care. So that concludes our speakers for today. And we have a few minutes left for questions and answers, if anybody has any.
Dr. Guskin? Yeah. Sorry.
May I say a few words? Thanks a lot to everybody. We have underlined, or you have underlined, almost all the important points. But my concern is, how are we going to realize all these? Our target population is the students, and we have 3 of them among us. And in this speedy world, I'm afraid people do not have much time to listen to these valuable things discussed here. And how are we going to put these into reality? I would like to ask this question to the younger friends. How are we going to do this? That's my contribution, that's all.
Maybe I could go first. Nick has actually left. Nicholas and I actually have quite relatively similar training backgrounds. We are batchmates. One of the things we realize, at least among the younger psychiatrists in my country, is that more and more of us are embracing the idea of contextual. More and more of us are trained in third wave psychotherapy. And by training in that therapy, we actually incorporate that into our day-to-day practices, and that reflects in how we see cases and so on and so forth. I believe that if this wave of movement, and I do think that this wave of movement is not just limited to my country, I think more and more newer psychiatrists are embracing this similar form of training. Eventually, with time, the curriculum will adjust to this. Maybe not in the next 1 or 2 years, but it will, because the younger psychiatrists are the ones that's going to be in charge, the ones that are going to be involved with mending and keeping this curriculum on board. And I think it will come eventually. It's just that if we want to push it harder, then that's where it's a bit more complicated, because I think the typical saying, if a younger psychiatrist go voice out in a very traditional meeting and where the curriculums are fixed, more often than not, we don't get heard so much, and that would come, that's a lot of work that we would need to do. But at least that's my opinion. I'm not sure, maybe Rodrigo would have another different opinion about this.
Not at all. Perhaps just simply to echo something you said about developing a narrative of the person's story. Something we found ourselves doing here when teaching about addiction is the students need to develop an assessment report that basically mirrors all assessment reports, demographic information, referral, presenting circumstances, etc., etc. But then at the end, there is also something they need to do that closes the report, which is called, and soon to be changed, problem formulation, because it emphasizes the problem rather than other things of the report. And the student needs to then have one brief paragraph of a very clinical presentation of the client, saying things like age, gender, diagnosis, and risks. But then another 2 or 3 paragraphs where the client needs to develop the story of the client, of the person's situation, from predisposing factors to perpetuating factors, precipitating factors, protecting factors, and they need to tell the story of was raised in this way, then this happened, and this is the issue that seems to be sustaining the problem, but there are these other strengths here available that we can use perhaps in developing our intervention plan. So creating that story that brings some individually in humanity to the way in which the person is seen. I think that's definitely a very useful way of incorporating that side of things.
All right, everyone. It seems that we have a special guest with us here today. Professor Afzal Javed. He's here. He is the president of the World Psychiatric Association. So, Professor Afzal, if you mind sharing your thoughts, if you don't mind sharing your thoughts.
Well, I don't. Can you hear me?
Yes, yes, we can.
Yeah, no, I don't have any slides or anything to share. If it is okay, I can just start. Thank you very much, Professor Koskan, for inviting me. It's really a great job that you and your group are doing, especially in relation to a number of activities relating to promotion of psychiatry. I think the topic which I hope that Professor Koskan and all other colleagues are discussing about the psychiatry curriculum for medical students. I have got some observations. Number one, the best option for WPA, and I'm speaking for WPA and on behalf of WPA, we have got a very active scientific section on education. So the first thing is that any recommendations which this particular group wants to make, we will appreciate if those recommendations can be sent to our scientific section, because that is the process that we really take it for any future progress, number one. And number two, the most important thing which probably needs a revision or a suggestion for revision, of course, WPA can only try for that. It will depend on the individual institutions and the universities and the member societies and individual countries that should really try to make such changes, is about how can we incorporate the current trends of teaching into our teaching methods. I think it is more than the contents. It is the format, it is the procedure, it is how we should really impart the psychiatric knowledge to our students. We have to really get the experts like Professor Rachel Jenkins, who has spent almost all her life in promoting and speaking about these policy changes. So probably WPA would like to know, in addition to the contents, that what should be the new formats. Now, for example, during the last year and a half, the COVID situation has made a number of innovations in medical teaching. Now, is it sustainable? How does our students respond to that? We need to find out that whether the new methods of teaching involving all these virtual methods were really effective, and were they getting the approval of our medical students? Because at the end of the day, although the role of teacher is very important, the role and the acceptance of the medical student sitting on the other side of the table is equally important. So that is my second suggestion, that not only the contents, but also the format. And the third thing is about the contents. Unfortunately, we can, and I'm speaking on my behalf and on behalf of WPA, that WPA can only give some generic guidelines, because each country, each culture, each institution has got their own way of formatting and establishing the curriculum. So rather than going into lot many details, if we could agree on some guiding principles. For example, and this is just an example, that we need to put a lot of emphasis in psychiatric teaching on the public mental health approaches. Because this is very important, that our students who will be looking after these patients when they will be in their future career, we need to emphasize that how the public health approach can be incorporated into the practice of psychiatry. I'm sure that most of you know that even at a WHO or UN level, now when these international organizations talk about NCDs, non-communicable diseases, they have included mental health as one of the NCDs. I feel this is a very, very big achievement, because now we can always try to say that as teaching of oncology, respiratory medicine, cardiovascular medicine, obesity, diabetes is important for future policies, the mental health is equally important and vital. So we have to take up these ideas and guidelines which could help the policymakers. The next thing is about the mode of examination. Again, WPA as an organization may not have an influence, but we can always recommend that at the end of the placement of medical students, what should be the minimum criteria that we should assume and we should accept that our medical students should be fully aware and should be sensitized about the need of what needs to be learned, what needs to be taught. During this current triennium, we established an action group on promoting psychiatry among medical students. We have published a number of papers. We are doing an international survey. We have prepared a video just asking the medical students that why psychiatry is important. Because until and unless the message comes from you, we people are already in the field. If we will promote psychiatry, any medical student can say, well, look, you have to promote psychiatry, but because you are in psychiatry for 40 years. So we need you people to tell us why psychiatry is important. And then last but not the least is the linkage of physical health, physical morbidities with mental morbidities. Again, during this triennium, we have got a very active action plan group on comorbidity of mental disorders led by Professor Norman Sartorius. So we are promoting and providing general webinars, not only for the psychiatric colleagues, but more importantly for non-psychiatric colleagues, that why mental health is important when we are talking about physical comorbidity. So these are some of the suggestions and ideas, and we would certainly welcome. But reinventing the wheel, I mean, rather than that, if we could really focus how and what needs to be really recommended. And of course, I can assure you that we as an international body will try to do whatever we want to do. And Professor Koskan has been a sort of an important leader of WPA's section on education. And I'm sure that he knows how important that section is in the WPA structure. So thank you very much. I hope, Professor Koskan, I have been able to speak about few practical points.
Of course, thank you very much, Dr. Hassan.
Thank you so much, Dr. Javed, for sharing your insight on how we can promote psychiatry. So seeing as how that is all of our speakers for today, are there any questions for any of them?
If I may, I actually have a question. Well, first of all, I'd like to just comment a little on, I'd like to just point out that I really like the question that Dr. Javed pointed out. What is the minimum criteria for what needs to be learned by medical students with regards to psychiatry? I think it's very apt for psychiatry because, well, we use the DSM and the DSM is full of criteria. So if we want to know what needs to be taught to the medical students, well, we need to have a set of criteria that we can sort of, to guide us, not really to follow strictly, but at least to guide us. But yeah, my personal question would be, we know that the prevalence of mental health disorders among medical students is actually higher than the general population. And we know that the prevalence of mental health disorders or psychiatric conditions in doctors, in physicians are even higher than that of medical students. So how can us changing or adapting our new psychiatric education in the medical curriculum help this situation? And is there some way where we can reduce the prevalence of these mental health disorders among these two populations?
Well, I think this is a very relevant and appropriate question. And we know that our medical students in particular are undergoing a lot of stress about the education, a lot of stress about the environment, and a lot of stress about the future. So this is very, very relevant and very appropriate. My approach to this particular issue is that, number one, we need to sensitize our medical students that mental health problems are also health problems, and these need to be taken as health problems and need to be consulted and need to be shared with some of the experts in this area. Because like many part of the population, medical students may not even come forward to discuss their psychosocial problems or psychological issues or difficulties with their colleagues, with their friends, or with their teachers. So this is one point, that we have to sensitize that mental health is an integral part of your health. The second stage, we should also try to establish some sort of ongoing support in our own institutions. I'm sure that if, rather than myself or Professor Koskan goes to a university and say that you open a health center or a health facility for medical students, if you people go to your own institution, that will have more voice. The third thing is that before we go forward, of course, we need to sensitize and we need to convince our own professional colleagues that while we are taking care of the general population, we have to put more emphasis on building a sense of wellness among our medical students. So these are some of the practical steps. In terms of convincing the policymakers, I always feel that you should have a data. For example, if you are going to the vice chancellor or dean of your university, you should have the data, and we have got enough data at this moment that certainly supports that doctors and medical students are under a lot of pressure. Now, there has been a sort of a new initiative that WPA is undertaking, that is to look at the burnout of medical students. One of our previous presidents of WPA, he has done a very extensive work, and there was a big publication comprising of reports from, I think, more than 6 or 7 countries on this particular topic, burnout of medical students. I think that was published, and I can always send that reference to Professor Koskan. So that was a sort of an important tool in our hands that we can take it to our individual institutions and say that, look, we are not just asking for the sake of asking, here is evidence. The third thing is that, looking at this issue of burnout, and especially with reference to the COVID-19, I am having a specific session in our next World Congress, a panel discussion on this particular issue of burnt out of mental health, burnt out of health professionals. And in that session, we are also referring to the issue of burnout of medical students. There is a number of publications. There is a number of future directions in that sense. And I will be more than happy to share that information with Professor Koskan. And even our group on medical students has also done and is also involved in just collecting some data. And I would encourage that your group in Turkey, your group that has got a lot of international connections, you should also look at the extent, the pattern, but more importantly, how to address this issue. I'm not sure whether you are happy or convinced with the answer, but I fully agree with your concerns about this issue.
Thank you very much, Dr. Javed. I think,
and just last but not the least, our WPA Secretary Education, Professor Roger Eng from Hong Kong. He will try to join us, but he is currently working on this medical curriculum. So please feel free to send us your recommendations, your ideas, which if you can't send him directly, you send it to me through Professor Koskan, and then I will make sure that all those details are forwarded to him.
Eventually, he was with us. He just left.
Oh, he just left. Okay, that's fine. That's fine, because I know from the chain of emails that he was in a clinic. He said that he will try to come. Good. And I'm sure he must have spoken about it.
Can I make 2 comments? One is relating to what Professor Bullen said just now. This question is quite challenging to all of us, at least all those who spoke. How are we going to do these changes? A lot of ideas that come across, but how are we going to carry it out? somewhere along the line, I think quite a number of speakers alluded to the fact that the students should be encouraged to make these changes. I'm quite fascinated by that because I'm a great believer in students. As I said, I've been teaching for many, many decades. And I've seen the changes come about, generated by students. But for the most part, I still believe that teachers have something to contribute to this. My question to all of you actually is, how many people in this forum, of course, one or two have left, but how many people in this forum have managed to promote, as Dr. Aparao mentioned just now, to promote this psychological, cultural, and social issues as a mainstream of the emphasis in the student teaching, so that students are aware that it's not just signs and symptoms and delusions and hallucinations and all that, but also there are real issues relating to families, marriages, jobs, COVID, and so many other issues. We don't seem to address this in our teaching, our daily teaching, whether it is in the psychiatric ward or the psychiatric clinic or anywhere, but we are asking our students to do it. So my question to all of you is, I think this comes from what Professor Jenkins mentioned some time ago when I asked the question. How many schools in Britain actually teach anxiety, depression, cultural issues and psychosocial aspects as the main part of their teaching? Anxiety, depression in a medical surgical ward, for example, as a regular part, maybe as liaison psychiatry once or twice. How many of them actually teaches at the mainstream? That's what the WHO has mentioned, that we should be teaching psychiatry in the primary care settings. Now, how many of us after 20 years, how many teachers are doing this? We are asking our students to do this, but how many of us are doing it ourselves, even in the high income and the middle and the lower income countries? So that's my question.
Professor Koskan, can I just comment what Professor Diva has said?
Sure, but the moderators are the young colleagues. But
yeah, sorry.
I believe they would ask you to contribute. Please do so, sir.
Well, I think Professor Diva is right, but I must say that the time has gone, and there has been many countries, not all, whether these are low income, middle income, or high income, there has been a change in the curriculum. Now, the issue here is that psychiatry is usually given a slot of few weeks, whether this is in UK, whether this is somewhere else. This depends on us, the teachers, that how we would like to expose our students for that particular period, number one. Number two, the other thing, the situation is not that bad. I can only give you one example from a low-income country, and that is Pakistan. We have been able to include the subject of behavioral sciences as an examination subject. Now, we have even gone beyond that. We have combined that as behavioral sciences and psychiatry. And now in 2 universities in Pakistan, this is an exam subject for undergraduate medical education. I think there is a way if there is a will. So probably once we have got this prominence that psychiatry or mental health needs to be examined, then the next stage comes what needs to be included and what needs to be examined. I am involved in teaching with the University of Warwick in UK. Here, in the final exam, the clinical exam, at least out of 5 or 6 clinical cases, 2 cases are must coming from psychiatry and mental health. And the question that is assessed is how to examine a patient, what are the appropriate and relevant questions that needs to be asked in terms of getting the history, and what are the formulation of the student in terms of looking at the needs and the assessments and the management of that patient. I think the situation is changing. And probably we need to be, and why I said that the medical students' help and support is important, because if a faculty member just goes to the dean will always say, well, you are a psychiatrist, you have to defend psychiatry. I think now the time is that if we can motivate our students, that they tell their education departments that, look, these are the changes that need to come. And I'm sure in many countries, not all, not many, but in some countries, the culture is changing. Let's hope that we see this changed culture in our lives. Otherwise, these students who are coming forward are our future leaders.
Can I just respond to that very quickly? I think Professor Javed was not here when I presented. And I actually mentioned this, that the curriculum can be changed any minute by any teacher. Because in medical schools, I've worked in 7 medical schools, including one in Britain. I can assure you the medical schools really don't worry too much about what you put in the psychiatric curriculum. They only want to give you so many hours, so many weeks, but they don't care what you do in it. All over the world is the same. So if you taught primary care psychiatry, stress, culture, society, and problems of human life, rather than psychosis and schizophrenia, nobody say no. I give you an example. In Brazil, they teach psychoanalysis. I mean, you may laugh at that, but they do it. How are they able to do that in Brazil? Psychoanalysis, I thought, was dead long ago. Why are they doing that? That's because the medical school talks about big things like curriculum. But when it comes to the actual teaching, whether you teach an anxiety depression patient or you teach a schizophrenic, that's the teacher's responsibility. And unfortunately, though you are giving the example of one developing country where 2 medical schools are now included psychiatry, this has been done in many other developing schools for more than half a century. In India, for example, till today, next to your home country of Pakistan, in India till today, they do not have an examination for the final year to pass out in the MBBS. Now, I agree with you. I'm a great optimist. I'd like to believe that all this will someday come about. I think you and I won't live that long. I think the changes we can do to the curriculum should not be passed on to the students out of our irresponsibility. We can still do it. In Warwick, I think if you go there and say, let's teach 2 weeks of anxiety, depression in primary care, not in the psychiatric ward, I'd like to see who is the dean who's going to object to that. But your lecturers might object because they are completely stoned in the belief that psychiatry is psychosis and psychosis is psychiatry. You look at the what do you call this, the ICD-10 and the soon to come ICD-11. Where is psychiatry compared to anxiety and depression? Anxiety and depression make up more than 50% of the patient load in the world. Psychiatry comes something like about 7%. And what's happening to psychosis? Psychosis is on the top. Organic mental disorders is not in the ICD-11 that's coming out. It's embargoed, so we can't see it now. But it's there. And what's happened to anxiety and depression? It's like right down. So it clearly shows there are fundamental errors that we need to change. I fully agree that medical students can do a marvelous job, better than you and me for sure. But I think we need to look into it, that we do both. Pass it to the medical students, but don't abdicate your responsibilities. I would strongly urge that august bodies like the WPA and the World Federation and so on and the WHO for that matter, should do a little bit more than they can do. They can do. There's nothing to stop them from changing curriculum. Nothing. I have changed my curriculum many years ago, more than 20 years ago, and it's remained till now. It can be done. Thank you.
Well, I just wanted to add something that I come from a developing country as well, and I know that in our training it follows perhaps a very old-fashioned structure in that we don't have, for instance, something that we have here in New Zealand, which is an online Canvas page, an online software where students can access resources, recorded lectures, and they can have a calendar with their assignments and things like that. And it is more, everything is done more in person and than that. But the pandemic has definitely shown us the usefulness of these tools that we haven't fully considered or fully incorporated in our teaching. And in that sense, they might have opened a space that we can make use of by some of the content perhaps that cannot be taught in a classroom, or that cannot be taught in a clinical space, can be then added, and of course in the appropriate format in an online setting, so that we make sure that students come out with a more holistic understanding of what a mental health disorder is, the social determinants of health that frame it, and public health approaches to it, and things like that. So yeah, just to build on what Professor Javed was saying about the importance not only on the content, but also on the format. And that is something that we have been seeing during the pandemic, that, yeah, of course, we wouldn't want to overload our students with more and more content that they need to know, but as much as possible, as much as it is useful, depending on the criteria, as it was said, of what is it that we want our medical students to know for sure before they come out.
All right, so I think we are a bit pressed for time today. So I'd like to thank all the speakers for their contributions. And yeah, I guess we can sign off. But before that, could we have a commemorative photograph on Zoom? Dr. Choshkun, would you be taking the photo?
Yeah, I did. Thanks to all of you, especially to Ramin and Asmita, Eugene, Rodrigo, and the others. Can I ask to get some notes out of this valuable meeting? We have indeed underlined very important points. Thanks to all who have contributed. Now, goodbye for now. Hope to meet at other meetings.